Good morning, everyone. Welcome to the Arthritis web seminar series. Today's lecture is lecture number 23, and our distinguished guest speaker today is Dr. Francis Berenbaum, all the way from France. He's going to be talking about how deep should we go to phenotype osteoarthritis. Before we start the introductions, just a reminder to the audience, please post your questions on the question answer tab on Zoom. Over to you, Rob.
It's a great pleasure to welcome Dr. Berenbaum to our virtual seminar today. Francis is the professor of rheumatology at the Sorbonne Université and the director of rheumatology at the Saint-Antoine Hôpital at Paris. He's a former president of ORSI and also has been president of the French Society of Rheumatology. He's associate editor of the Annals of Rheumatic Disease, and he currently leads an experimental team in INSERM Institute. His basic research interests including understanding of the relationship between metabolic diseases and osteoarthritis, and his clinical focus is on new targeted therapies for treating signs and structural changes in osteoarthritis. He's very actively involved in clinical trials and has published more than 300 peer-reviewed publications. Dr. Berenbaum was the recipient of the annual ORSI Clinical Research Award in 2017. Francis, bienvenue.
Merci beaucoup. So I will switch to English speaking. First of all, I really would like to thank you for your invitation, in particular Mohit and Bob for participating in these really prestigious web conferences. And I listened to the others, and I'm very impressed by what you are doing with these web conferences. So I'm very, very pleased to participate in this conference because, as you know, it's one of my favorite research topics, and it's currently undergoing a real revolution, as you will see. So these are my disclosures. And so just to introduce the topic, here are some figures that will show you that osteoarthritis is a real public health problem that has not yet been resolved. It's considered that approximately 10 to 15% of the world's population has symptoms of osteoarthritis, namely pain and limitation of the function of one or more joints, essentially causing an alteration in the quality of life of those affected. Since this disease does not only affect the elderly, contrary to what many people believe, the economic impact is considerable due to lost work days. In addition to these consequences on the quality of life and work, it's now known that this disease is associated with an increase in mortality. And this is particularly due to the cardiovascular consequences to the sedentary lifestyle that it causes essentially when there is OA in the hip or in the knee, aggravating all cardiometabolic diseases because of the sedentary lifestyle. This is the reason why the FDA has now classified this pathology as a serious disease, recognizing the need to quickly find treatment to limit its consequences. And the main reason why we have reached these dramatic figures is the absence of curative treatment, with only a few symptomatic treatments at our disposal, which are often not very effective or poorly tolerated. Even the prosthetic surgery is not a panacea, in particular for the knee, because there is a chronic persistent pain in 20% of the patient, despite the correct placement of the total prosthesis. Everything has been well done during the surgery, but there is this risk of a persistent pain. However, there is it's not for lack of trying many molecules in the recent years, including targeted treatments such as certain biotherapies targeting TNF, adalimumab, etanercept, targeting IL-6, tocilizumab, IL-1, anakinra, or lutikizumab, which is an anti-IL-1 alpha-beta antibody, or other chemical molecules targeting particular enzyme like MMP inhibitor, ADAMTS5 inhibitor, cathepsin K inhibitor, or a particular tissue like risedronate, which could target bone metabolism. So it's therefore legitimate to ask the question, why so many failures in this disease? And I will just give you a few answers to this critical question. So perhaps the initial hypothesis was wrong after all. We made a mistake in the reasoning without even knowing why sometimes. You see on that picture the main targets that have been in development for the last years. You see, for example, FGF18, sprifermin, NGF, Wnt inhibitor, and in light yellow, the animal models suggesting that these are the right targets, and in the strong yellow, the corresponding human trials. So let's take one example with ADAMTS5. And you know that there are numerous publications in leading journals such as Nature that have shown that ADAMTS5, which is an enzyme that is capable of cleaving aggregain, is present in cartilage and may play a major role in the OA process by promoting this cartilage degradation. So it's therefore logical to hypothesize that an inhibitor of this enzyme could delay the OA process. There are murine models that confirm that with ADAMTS5 knockout mice. And so it was logical to test it and to confirm that in human. And as you can see here on this on this slide, that there are some these preliminary studies were very encouraging, and just look at the biomarker data showing a reduction of the serum ARGS, which is a biomarker of proteolytic degradation of aggregain in articular cartilage. So they launched a phase 2 study, and 850 patients, and unfortunately this failed. And so the initial hypothesis maybe was wrong. So the reasons for the failure of a trial maybe the bioavailability problem, a tolerance problem, as we experienced as example about 15 years ago with the MMP inhibitor, having musculoskeletal toxicity and interrupting the development program. However, I would like to focus on another explanation that is particularly interesting because it may have the effect of modifying our future practice, both in the therapeutic field and more generally in the management of people affected by the disease. It's the hypothesis that these successive failures are linked to the heterogeneity of the OA disease. Let's take a very illustrative example, I think, even if it's outside of our specialty. It's the peptic ulcer disease. In blue, you have 100 patients, it's just theory, with ulcer, and you decide to give an antibiotic to any patient with a peptic ulcer disease. And in orange, the proportion of the patients that still have peptic ulcer after 6 weeks of treatment. No big difference, no statistical difference. So you might conclude that the antibiotic is not a treatment for the ulcer, and so you stop the development. Now you identify and treat only those patients with ulcer disease with the presence of Helicobacter pylori because you have some experimental data suggesting that maybe this could have an effect. And so you have identified two phenotypes of the same disease, and we'll treat only one of these phenotypes. The difference is now highly significant. And so you are showing that antibiotics are effective, but just in one of these two phenotypes. In fact, you have reduced the heterogeneity of the disease you are studying thanks to a diagnostic test, here a biological, but it could just as well be clinical or genetic or radiological. And so you are refining the classification of the disease in order to improve its treatment. So let's move to an example closer to our topic. So here you see the results of an analysis performed in the Osteoarthritis Initiative cohort. You know, this very well-known US cohort with a multi-year follow-up of NeoWay. They took 1,755 participants from this cohort, and they followed these patients for 4 years. They had mild osteoarthritis with X-rays performed every year. And using a latent class growth analysis, they identified two distinct subgroups. The first one corresponds to patients who has not had any progression of OA, and they represent a great majority with 90% of these patients, which are non-progressors. And the second group, entitled progressors, corresponds to patients who have seen a significant joint space narrowing in fewer. So we therefore see here two different phenotypes, progressors and non-progressors. So now let's assume that you have a drug capable to slowing down the progression of joint space narrowing. If we give the treatment to all, we have a great chance of not seeing any effect, since the space for improvement is almost non-existent for 90% of the patient. On the other hand, if we test the treatment only in the progressors phenotype, we have the possibility to demonstrate an effect of our drug. So these patients may be appropriate candidates for clinical trials of disease-modifying OA drugs. So in other words, enriching such trials with progressors at inclusion increase your chance to find a positive effect of the tested drugs. So after this brief introduction, let's get to the heart of our subject. First of all, how is a phenotype defined? So I found this definition. I know that there are many other definitions, but I like this one, which is the sum total of observable characteristics of an individual regarded as the consequences of the interaction of the individual's genotype and environment, a variety of an organism distinguished by observable characteristics rather than underlying genetic features. For example, height depends on genetic factors, but also on the nutritional environment during childhood. So another way to define subgroups of a disease can be the endotypes. So what is an endotype? It's a subtype of a disease defined functionally and pathologically by a molecular mechanism. For example, if you have a breast cancer can be estrogen receptor positive or estrogen receptor negative, and this implies different prognosis and treatments. And a phenotype often has several endotypes. Again, for the breast cancer, you have the estrogen classification, but you also have the epidermal growth factor, HER2 classification, and so on. So you have different prognostic outcomes and treatment responses according to that. So now let's apply this definition to OA and see where we are in 2021. exactly 10 years ago. Here was, you see here what I proposed in this review. I know there are many other possibilities, but this is one I proposed 10 years ago. And these are based, it was based mainly on my clinical experience. As you can see, there are these main phenotypes are related to main risk factors. Post-trauma OA, OA associated with the metabolic syndrome, OA related to aging, as well as rare genetic OA disease. And I also individualized the pain as a phenotype, even though it didn't really know what to put behind it at this time. But I thought it still answered to the definition of a phenotype, since for the same joint destruction, some people will have no pain, while others will suffer a lot, with behind it probably interaction between genetic and environmental factors. So in fact, there are many factors that can help define phenotypes of patients, clinical factors, of course, such as the number of joints affected, the localization, and so on, or biological factors, such as the presence of inflammation, hormonal factors, genetic factors, and also imaging factors, such as the subchondral bone density, erosions on X-rays, synovial inflammation, bone marrow lesions on MRI. And this is one example of how imaging phenotyping could lead to personalizing the treatment in the future. You see extensive synovitis on an MRI, and so you will consider that you will use cytokine inhibition, because you consider that this will much more targeting people with having synovitis, or using drugs that are targeting bone metabolism if you see bone marrow lesions on OA. So this is one example how by such phenotyping you can imagine how you will target for a structural or a symptomatic modification treatment. On the same page now, how that could lead to a personalized medicine. So this is very easy to understand. You have a post-trauma OA. In clinical practice every day, you will think on how to prevent trauma. You have a patient with obesity and OA. You will, of course, think of losing weight. So you see, that's what we do in practice every day. We use clinical phenotype and we apply preventing strategies or even treatment strategies to have an impact for these patients. But of course, the question is, can we do better than that? So to illustrate how we could go in that direction, I will now present a very recent work that we have just published. And this is some kind of a proof of concept. 7 French teams have joined forces to search for TGF-beta signature specific to a given phenotype. So for this, we identified 6 phenotypes found in humans by trying to find an homologue in mice. So these 6 phenotypes were the following. For post-trauma OA, we used the meniscectomy model. For age-related OA, we're letting the mice grow old. For inflammatory OA with intra-articular injection of collagenase. Obesity-related OA with a high-fat mouse model. Maybe more original, for the metabolic syndrome associated OA, we used a sapin knockout mouse model, which is a model similar to a human congenital lipodystrophy, which is characterized by almost complete loss of adipose tissue, insulin resistance, fatty liver, but all that without overweight. And finally, osteoarthritis, by mechanical overweight without metabolic disease, with a very, very original model coming from Saint-Antoine in France. It's a model with mice exposed to hypergravity. Maybe you will show. I'm trying to show you what that could be. Excuse me, it's not this one. Yes, so, yes, okay. Okay, so you see here the mice are centrifuge at an acceleration of 2 g, and curiously, after a short period of adaptation, the mice live normally in these cages subjected to centrifugation. So very, very original model. And at the experiment end, the knee joints were harvested and the femoral condyles and tibial plateaus were prepared for histological analysis and RNA isolation, respectively. OA severity was scored after safranin O staining using the ORC grading system, and only the animals with the same ORC grading were analyzed in order to avoid the modifications not related to the phenotype, but only to the OA severity. And the expression of genes involved in TGF-beta signaling was assessed using custom-made TACMAN records. And the originality of this study lies in the effort to standardize each step of the analysis in order to minimize the problems related to reproducibility. The control groups were the surgical models, and all the surgeries were performed by the same investigator who traveled to each of the centers that developed his own animal model. So as an example, the investigator who performed the surgery traveled to Saint-Étienne to perform the surgery on the mice in the centrifugation model. And similarly, the histological analysis was centralized, as well as the RNA extraction and the gene array analysis. And as you see here, as a results, on the left, you have the Venn diagram, which shows indeed unique and distinct TGF-beta transcriptomic signatures according to the phenotype. And on the right, the fold changes of these genes by phenotype. No gene was deregulated in all 6 OA models. That was, we were very surprised by that. Of course, I will not go into the details in this during this lecture. It's not the purpose of my presentation, but you just see here one example of an application of the concept of phenotyping by risk factor to identify distinct signatures that may open to targeted therapies, maybe here based on the TGF-beta pathway. But just this is just one example. Another way of phenotyping, which is called the prognostic phenotyping, it consists of looking at different trajectory profiles without having any preconceived ideas, no a priori, but only letting the statistical analysis classify according to this objective. So a classical analysis for such an objective consists in latent class growth analysis. I do not know so much about all the details of statistics, but just to tell you that it's a tool that has been developed to estimate individual change over time. In other words, the objective is to classify individuals into subgroups based on their longitudinal data. And this is just one example of using group trajectory modeling to identify pain trajectories based on data coming from the famous video clinical trial. You know, this trial with a 3-year follow-up of around 500 patients, if I remember, receiving or not vitamin D. The identified group of pain trajectories, and so they define 4 OA phenotype: the low fluctuating one, mild increasing one, moderately treatment sensitive, and severely treatment insensitive pain. What is interesting is that based on this phenotyping, they were able to identify a severe pain phenotype that did not benefit from available treatments, and another one more likely to benefit from knee replacement. So you see that it's possible to identify phenotypes of knee OA based on the pain experienced by patient, as long as you have the longitudinal data. You really need to that the longitudinal data are available. So yes, I will make a very long story short in terms of clinical phenotypes. There have been published recently in 2016 a systematic literature review based on 24 studies, and they have by this way identified 6 usually coming in the literature, 6 phenotypes: the chronic pain, in which the central mechanisms are prominent, the inflammatory phenotype with high level of inflammatory biomarkers, the metabolic syndrome phenotype with high prevalence of obesity, diabetes, and other metabolic disturbances, the bone and cartilage metabolism with alteration in local tissue metabolism, the mechanical overload, which is characterized by varus malalignment and medial compartment disease, and the minimal joint disease characterized by minor clinical symptoms, but slow progression over time. So these are classification based on clinical data. So where are we this time regarding endotyping in OA? You see on this slide that endotyping for OA is mainly aimed at identifying subgroups based on molecular differences in the tissues of the joint. And this may be molecular differences in signaling, inflammation, bone parameters, and so on. And I will give you 2 examples. One very, very exciting example is this one recently published in the Annals of Rheumatic Disease. This is a study in which they performed a single-cell study on cartilage coming from OA patients. They first isolated human OA chondrocytes at different stages, obtained from articular cartilage of 10 patients undergoing knee arthroplasty surgery, and they performed a single-cell RNA-seq of all these 1,600 chondrocytes, one by one. And of course, it's based on very sophisticated methods for clustering analysis. And by this way, they identified 7 putative cell clusters, including 4 empirically defined populations, the non-proliferative chondrocyte, pre-hypertrophic, hypertrophic fibrocartilage, but also 3 novel populations named effector chondrocytes, regulatory chondrocytes, and homeostatic chondrocytes. That's how they call this chondrocyte. So this is just a heat map revealing the expression of differentially expressed genes for each cluster. At the top, you see the name of these clusters, and on the right, some genes that have different expression levels according to the cell type. And what is really, really amazing is that they studied the relationships between all these 7 chondrocyte clusters and the stage of OR cartilage severity from which these chondrocytes originated. And so this is based on around 20,000 genes, and the samples were stratified into two groups, those with expression levels above or below the cutoff values determined on the basis of each individual gene profile. And by this way, they identify 336 predictive genes classified into two types, the predictive genes linked to favorable outcomes and the other one on unfavorable outcomes. And then they assessed the distribution of predictive genes in each cell type. And they found that the distribution of these favorable and unfavorable predictive genes varied among chondrocyte population, as you can see on this slide. And the favorable genes were predominantly expressed in you see here the EC, RegC, and HOMC. I will not go into all these details, and the unfavorable genes with other chondrocyte phenotype. And the hypothesis that some of these chondrocytes may protect the cartilage from the onset of OA, whereas the other ones may promote for OA progression. And so what is not yet known, of course, is whether an individual signature established from the quantitative distribution between these seven different chondrocyte population at an early stage of OA can predict the outcome. But you see in this example how a classification by endotypes could open up a new diagnostic, prognostic, or therapeutic path. Very rapidly, another example just published from another Chinese group who collected three types of tissue, including cartilage, subchondral bone, and synovium from multiple clinical centers. And they constructed an extensive transcriptome atlas of OA patients, and they applied an unsupervised clustering analysis to the cartilage transcriptome coming from these OA patients, and they were able to make a classification into 4 subtypes with distinct molecular signatures. So another way, by endotyping, how this could lead to descriptive to descript the clinical features, to describe that, and also to have some indication of what could be the best drugs to apply. This is very preliminary, but very, very interesting. So now the question is, can we go even further in phenotyping our patients? And this question has been raised since we entered into the world of big data. And so until recently, we know that we can collect and analyze a few hundreds of individual data for establishing this phenotyping profile, as I showed you earlier. But now we are facing not hundreds, but even thousands, but millions of individual data that have a considerable informative potential. The problem was that until now we were unable to process these masses of data. Their processing was beyond our computing capabilities. But now, with big data analysis technologies, including artificial intelligence algorithms that have progressed so much in the last few years. And so now we can dream of integrating these millions of data to produce much more precise phenotype signatures. In our field of interest, by collecting demographic data, including, for example, all the data present in the patient's environment, you know what now is called exposome, the clinical and biological data with the metabolomic from urine and blood, or the metagenomic from the stools, or the proteomic analysis from the synovial fluid, or even the single cell studies, as we have just seen before with the tissue analysis, genetics with the transcriptomic analysis, microRNA omic analysis. So now this could maybe open to what we hope will be this deep phenotyping. In other words, will we be able to integrate these multitudes of data from environment genetics, epigenetics, to define different phenotypes that will determine different outcomes in terms of morbidity or even mortality or different therapeutic responses? So until now, we have been able to analyze large quantities of data obtained by omics technology, but omics by omics only. This is what is called reductionist model. Omics by omics, meaning genomics only, proteomics only, metabolomics only, radiomics only, so all the data coming from imaging. Interactomics only, which is the whole set of molecular interaction in particular cells. But the objective of deep phenotyping is to go even further by trying to integrate all these layers to really achieve a global knowledge of a disease. You see the level of the challenge. So by this way, we could improve our phenotypic precision to such an extent that we could envisage treatments perfectly adapted to the person and not what we do today, which is a one size fits all. And before closing my presentation, because I think we are very close to that, I just would like to share with you an ongoing study with some very preliminary data I have not yet presented. It's more about showing you how concretely what I've just presented in these last slides could lead perhaps in the near future to this goal of precision phenotyping. So this is the transcriptome, the transimmunome study, which is an integrative and a system biology study, which aims to define multi-omic signatures of different inflammatory diseases, including osteoarthritis. And so we have in this study included 15 OA patients with the same Kellgren neurons, 2 or 3. And for each patient, we have collected the clinical biological with more than 500 variables. You see here the list with a deep immunophenotyping from peripheral blood, autoantibodies, deep immunoproteomics, whole blood transcriptome, TCR repertoire analysis, stool gut microbiome analysis for quantitative metagenomic approach. We also have, of course, the MRI and the X-rays of the knees. And I'm going to show you some very preliminary results which have been performed by the 3 persons you see on the right, top level, with Jérémy Selam, who is heading this study with Encarnita on the left, and Marie Benvignat, who is a fantastic fellow doing all this analysis with, of course, you will see at the end, a very large team, of course. So we first try to identify the clinical cluster through a dimensional reduction approach. We use here, I learned that with this study, what is called the FAMD methods, the factor analysis of mixed data. We have just included in this particular analysis only the quantitative and the qualitative variable based on the daily routine for a rheumatologist or a GP. And the quantitative variable are represented in blue on the left and the qualitative variable in red on the right. And you have their projection according to 2 artificial dimensions that maximize the separation. If you look closer on the graph, you distinguish different variables, contribution in these 4 quarters. On the upright, BMI, metabolic. So you see on the left, the blue and the red, okay, and you look in these 2 on the upright. You see BMI, the metabolic syndrome, diabetes, and CRP. Up left, you have the age, familial history of OA. Down left, male meniscectomy and ligamentoplasty history. And the right, WOMAC pain, DN4, and depression. So this is really just by clustering. And now you see each individual, so each point is one individual, projected on this previous FAMD analysis. And I just show you on the previous slide. And by this way, you can identify clusters according to a method based on another method, which is called the Gowers dissimilarity matrix. And you see here the distribution, which fits perfectly with the previous quarters. In red, a cluster of patients with high BMI, metabolic syndrome, diabetes, and high CRP. In green, a cluster of patients composed mostly of women with a familial history of OA slightly more aged. In blue, a cluster of men with unilateral OA and notion of meniscectomy of knee trauma. And in purple, a cluster of very symptomatic patients, mainly with neuropathic pain. And here are the very preliminary analysis on 19 OA patients with a heat map representation of the expression of differentially expressed cytokines for each cluster. So each line is one cytokine with differential expression according to the cluster. And you see the cluster aging seems to be very different from the others, and maybe also the neuropathic pain cluster. But once again, this is based on a very small number of patients, so we should be very cautious for this interpretation at this stage. It's just to show you how we can go in that direction of deep phenotyping. This is the same, but for transcriptomic signatures with an analysis performed in 19 patients. We analyzed more than there was more than 1,000 differentially expressed gene. And you see here some overall heat map. The same also for the metagenomic by looking at operational taxonomic units. So really, my objective here was just to show you a kind of proof of concept of what could be a deep phenotyping approach in OA. Even if you have noticed, the most complicated and challenging step is missing. And what is missing is the integration of all these layers. And so we are not even at the step of just having the reduced model, as I showed you before, but after we will have to integrate all these layers, integrating also all the clinical data, also the imaging data. So a lot of work to do, to complete and have the complete signatures. So I will end here with this very nice figure from a very exciting review. I encourage you to read it, just in press in Osteoarthritis and Cartilage Open. It shows you very well what will be the strategy of phenotyping and stratification of an heterogeneous population of OA patients. For that, we need what? We need sophisticated technology platforms for analyzing fluids, for analyzing tissues. We need experts in the field of bioinformatics, computational science, management of big data in order to provide accurate algorithms. But, and I will end on that, what we need above all are clinicians, because the clinicians are capable of selecting the patients to be analyzed. This is very, very important. They will, the reason is that they will provide the diversity of the patient profiles that we see in consultation. This is very, very important, because if not, at the end, you will not get the right signatures. It's very important to have this heterogeneity first. And based on that, we will have a very, very exciting research results. So I just would like to close here to thank this huge team involved in transimmunome. The OA team, as I already told you, is on the right. Not only on right, you also have Encarnita coming from this lab from David Klatzmann, who is very well known for system biology science. Many experts in the field of system biology, a mix of computational experts, biology experts, immunologists, and so on. And thanks to this very fantastic team, we can work with them on this project. And also, of course, the whole team, research team, clinicians at Sorbonne University, INSERM Saint-Antoine Hospital, and we work all together in that field, and very, very happy to continue and try to find new prognostic markers and new ways to treat our patients in the future. Thank you.
Francis, beautiful talk. Thank you so much. We have questions coming up on Zoom. First question is by Dr. Frank Bayer. Great talk, Francis. Do we know how homogeneous for OA phenotype the 10 patients which were used in the single-cell RNA-seq study by G et al. Were?
Yes, of course, that's a very, very good question, because all these patients come from patients who will undergo the total joint prosthesis. So, of course, this question about homogenization and heterogeneization, I would make that in parallel, are the key question. I'm not sure that we can definitely use these 7 phenotypes of chondrocyte as the final answer. I really, and also this has not been yet replicated. So it needs, of course, to be replicated. But I think that it's really the first time that we can use very, very recent technologies on single cells in order to go deeper into endotyping. So that's much more the objective, I think, of such a study. Now, if it is replicated, that would be very, very important for the future. But I agree with you, Frank, about this very important question.
We have a question from Amanda Ali. Francis, thanks for a great presentation. The potential of deep phenotyping is clearly quite promising, especially if the omics technologies continue to advance. But a challenge remains is the external validation of the signatures that are identified in one cohort to independent cohorts. What do you see as the best strategy for addressing this challenge?
The response can be very easy. The response is collaboration. I think the time is closed where one team is working and in her laboratory, and then publish the results, and then another team will try to reproduce the results. I think that now we really have to work all together. We define one objective, and all the teams who want to be involved work together. I know that the question is always about what who will be the first author, the last, but this is the new world is not this one. The new world is like the physicians. I mean the physics, not the physicians, the doctors. I need the scientific, the scientists working in the physics field. If you look at the science paper, you have 100 authors, okay? It's not a problem. It should not be a problem. I know that the young investigators are attending this lecture say he's completely crazy. But I think that the future is really that we have to move now to really collaborating, because Ali, you are completely right. This is a big problem. Is the reproducibility. If we continue on working, even if we have one in one publication, we replicate with another another cohort and we publish the two cohorts. No, I think that in the future we have to work all together. There are not so many people, in fact, in the field. We are a very small world. We really can do that. And we have also to include not only rheumatologists or orthopedists, but we also have to include experts coming from other fields, cardiologists, endocrinologists, diabetologists, nephrologists, and so on. That, I know it seems to be very difficult to achieve, but if we really want to make a new step, like in cancer, we have to go in that direction.
Thank you, Francis. Next question is by Dr. Ali Gormazi. Merci, Francis, for this excellent presentation. Where you see the imaging playing a role in the characterization of OA phenotype?
I think it's central. Why it's central? It's because until today, when you are in front of a patient, how do you make the diagnosis? You make it by X-ray. Of course, for hand OA, even without X-ray, you will make you can have the diagnosis. But in fact, it is mainly based on very specific features. Osteophytes is the most striking feature for OA. It's of course an anatomical element, but it is seen on imaging. So it starts by imaging. And so, of course, I'm sure that for also prognostic reasons, because we know that the final stage of OA is when your joint is destructive. When there are no more cartilage and so on. And so imaging is really central. The question is, how are we going to integrate that on all these layers? This is very complicated, because of course, if we use X-rays, it's not so complicated. You just put one layer, which will be KL 1, 2, 3, 4. Okay, but if we want to go on a granularity that will include imaging at the same level of omics, you will have maybe to take into account the pixels of the MRI. Okay, so Ali, I really think that imaging should be one of these layers and not just looking at this layer and that's it. It needs to be integrated into all these layers.
There's the question here from Guangzhou Zai, France. Thanks for your talk. In your TGF-beta work, which subtype of GDF5 plays a role, do you think?
That's a very good question. You know, once again, I would not be definitive on that, but the GDF5 seems to be more linked to the aging process. If I remember, I have to go back to the transcriptomic analysis. But maybe if I know we just have a very short time, but this is here. So it's not here, but I thought maybe if you send me an email,
Yeah.
I will give you the right answer for that question, because I do not want to give you a wrong answer, and we'll have to go back to the transcriptomic analysis.
That's great.
A question about therapeutic, your thoughts conceptually about therapeutic trials. When we say an initiative like the ADAM-TS5 failed, in brackets, are we using the right outcome measures in these trials?
Of course, that's I was a little bit caricatural, okay? By taking, I wanted just to take one example that could be due to a wrong target, but you are right. It doesn't mean even if the clinical trial proof of concept was negative, it doesn't mean that it's not the right target, because this could be due to the outcome that has been chosen.
Yeah.
The problem is that as you know now, it's more complicated now that in order to consider that a target is the right one for disease modifying, it needs to demonstrate that it has an effect on a symptomatic outcome and on a structural outcome,
Right.
which is a very big challenge.
Yeah.
And so I think this is the problem, which is also the problem for the cathepsin K inhibitor, could be also a concern for the sprifermin, is that what is the best target in order to get at the end the label of disease modifying, since it has to demonstrate an effect on both outcomes. So
Right.
yeah, very important question.
So Francis, we are right on time, and thank you so much for joining us today. Great overview and great discussion.
Thank you. It was very great pleasure. Merci.
And also to the audience, thank you for attending today, and please join us on April 13, lecture by Dr. John Laughlin on arthritis and genetics. See you on April 13. Goodbye, Francis. Goodbye, everyone.
Goodbye.
Goodbye.